I'd like to introduce our speaker, Dr. Melissa Womble. She serves as the director of the Inova Sports Medicine Concussion Program and co-director of the Inova Concussion Program here in the system. Dr. Womble and her team built the Inova Sports Medicine Concussion Program to provide multidisciplinary, individualized care to patients who've sustained a concussion in the Northern Virginia area. She's authored or co-authored more than 30 peer-reviewed publications, delivered more than 60 presentations on sport-related concussion at national and international conferences. Dr. Womble will discuss common causes, symptoms, management techniques, and treatment options for concussion. So really a wide range presentation tonight. Dr. Womble joined Inova after completing a neuropsychology postdoctoral fellowship within the University of Pittsburgh's Medical Center in their sports medicine concussion program. She obtained her doctorate in combined integrated clinical and counseling psychology from the University of South Alabama in Mobile, after completing a pre-doctoral internship at the Henry Ford Medical Center in Detroit. Dr. Melissa Womble is also incredibly humble. She's going to give a fantastic presentation, and I can't thank her enough for her time tonight. Melissa, the floor is all yours.
Thanks for having me, Kevin. And thank you everyone for being here tonight. I'm really excited to be talking about concussion. It's obviously my passion to treat patients with concussion, and I've been treating patients with Inova since 2016. I actually grew up in the Northern Virginia area, and I always wanted to come back and serve our community. So I'm really glad you're here and can help spread good knowledge on concussion across our community. So to get started, I always think it's helpful to talk about myths with concussion. There's a lot of myths and bad information about concussion out there, as it has changed a lot over time. And one of a very common myth is that concussion only occurs as the result of a direct blow to the head. But what we know is that concussion may be caused by a direct blow to the head, face, neck, or an indirect hit elsewhere on the body if the force of the impact is transmitted to the head. So I often see, patients where, maybe their parent is questioning if it's actually a concussion because it wasn't a direct hit, but just know that concussions can also occur via indirect hits. Now, you may be wondering what a concussion is. Again, like I had mentioned, there's a lot of misinformation out there. And when you think about a concussion, when the force is transmitted to the head and the brain shakes hard enough, it negatively affects the neurons and cells within the brain. There's a chemical exchange that occurs during this process, and it leads to a toxic environment throughout the brain, which makes it hard for the cells to communicate and results in constriction of blood vessels. So there's a decrease in blood flow when the energy supply is reduced. It's kind of a mismatch. And that's why during recovery, we want to do everything we can to increase that energy supply. And we'll talk a little bit more about that. But the brain quickly starts to heal itself. And though this takes time and energy when, again, the energy supply is reduced. So what does that mean kind of in layman's terms? And I think the easiest way to express this, and the way I often express it to patients in clinic, is there's an energy crisis in the brain. And the brain is working less efficiently. So if you think about a gas tank, your brain's operating more on empty than on full. There's not bleeding, swelling, or bruising as commonly thought. And that's why no imaging or special tests are going to definitively show concussion. We have to utilize a very kind of extensive toolbox to be able to properly assess and diagnose the injury. Another myth or common myth is that concussion only occurs when an athlete experiences a loss of consciousness. But what we know is concussion can occur with or without loss of consciousness. And it's estimated that really only about 10% of concussions have a loss of consciousness with them. So about 90% do not have a loss of consciousness. The symptom of on-field dizziness is 7 times more predictive than any other symptom in terms of predicting longer recovery following concussion. And I bring this up, in that if your child or experiences a concussion and they are reporting dizziness right away, it's likely important that you're considering more specialty care because they may require therapies or treatments to help improve dizziness. I want to jump back to loss of consciousness that I had mentioned as well. And, I see a lot of patients come in with concern when loss of consciousness is present, but in a lot of cases, we actually see better outcomes when loss of consciousness is part of the injury. So, I say that with the idea that you don't have to freak out if there is a loss of consciousness. So concussion recognition is difficult. It's not like other injuries where there's, a lump on the head or there's a missing part, something that we can easily recognize. Again, as I had mentioned, it takes kind of a toolbox to really fully assess and diagnose the injury. A typical kind of new patient evaluation in our office takes about 45 minutes to an hour. So it's a pretty extensive visit to be able to properly look at the injury. Now, when we think about concussion treatment, there's really kind of four components. There's baselines that occur in many of the high schools around the area. We also do baselines in our clinic prior to the season. So a baseline is cognitive testing that is completed prior to the sports season. And this can be done, again, through your youth organization. It can be done through your athletic trainers in the local high schools. It can also be done through specialty clinics. On-field management, when an injury occurs and there's a suspected concussion, there's going to be on-field management, whether that's, via a coach, athletic trainer, parents. It kind of varies depending on the sporting situation, in-office treatment, and then return to play. And we're going to talk about all these different stages tonight. So we're going to first talk about baseline testing. So if you're not familiar with baseline testing, it's neurocognitive testing that is completed prior to the sports season to obtain a snapshot of cognitive functioning in the case a concussion should occur. So before a concussion happens, we have this snapshot of how your child is functioning before the injury happens. And neurocognitive testing assesses verbal memory, visual memory, processing speed, and reaction time. So through research, we have identified that these are the areas of cognitive functioning often affected post-concussion. So that's why we hone in specifically on those areas. And in the case of injury, comparison can be made between the baseline and the post-injury data. So we can put them side by side and look at them to make sure that individual reaches ultimately at the end of when they're recovered back to where they were at baseline. Now, you may be wondering, is there, if we don't have a baseline, what happens? And certainly we can compare, to normative data based on academic history, occupational history. We can utilize that as neuropsychologists. We're equipped to do that. But it is very nice to have that baseline, which again is your personal snapshot, because we do know that, for example, kids with ADHD, learning disabilities, they're not going to always perform the way we might expect them to based on the normative data. Additionally, there has been research showing, as in this article I have up on the screen, that if we utilize normative data for those individuals that are more above or who fall outside the average range and they're more above average students, it's going to underclassify or underrepresent their abilities. So particularly for those students who are, really good students, having a baseline is really important. Now, the next step to the treatment process is on-field management. And one of the common myths with concussion as far as on-field management is that it is safe for a player to return to the same game or practice after suffering concussion-related symptoms. And what we know is that there's 21 different signs and symptoms of concussion. And any player who suffers any signs or symptoms that are specific to concussion should not be allowed to return to the current game or practice, no matter how quickly the symptoms may clear. I know this is difficult. I have 3 kids of my own, and they're, starting in sports, and it's hard, especially if it's the last game of the season, whatever it may be. But the problem is that symptoms of concussion do not always present immediately. Instead, they evolve over time and even hours after injury. So sometimes we can see a kid who may immediately have a headache, and that may get better, but then they can continue to play and that headache comes back. And so, I know it's a difficult type thing, but if an athletic trainer or coach is telling you that your child should sit out, it's for a good reason to protect them from further injury. We've actually studied what happens if athletes continue to play following concussion. And this article by R.J. Elbin, who's our research director here at Inova, had shown that those athletes that were removed from play versus those that continued to play after sustaining a concussion were 8.8 times more likely to have a prolonged recovery. So by continuing to play in the game, they put them, they're now 8.8 times more likely to have a prolonged recovery. So you can see the average days if they were removed is 1 day recovery versus a 44-day recovery. But he looked at this a little bit further in a follow-up study and was looking at if there's a dose response for longer recovery in athletes who continue to play following a concussion. And what was found in that study is that there is a dose response. Even if you play, a couple more minutes, that extends it. But you can see here, those that were immediately removed recovered in 18.9 days. Those that continued for less than 15 minutes, 28.4 days. And those that continued for greater than 15 minutes, 44 days. So every minute matters. And that can extend recovery. A few other takeaways from these two studies was that continuing to play was associated with worse memory, reaction time, and greater number of symptoms that was demonstrated via neurocognitive testing. Again, athletes who stay in the game with concussion take twice as long to recover, and continuing for just a few minutes can have adverse effects on recovery time. So I think this is good information as a parent when your kid's fighting to go back in to kind of be able to talk them through this and the risks that are associated with going back in. Now, on-field management and sideline evaluation is difficult. Our local athletic trainers are definitely put up to the task. Coaches who are busy, supervising the game, trying to manage kids, they're also, put in a difficult position. There's really no perfect diagnostic test or marker for immediate diagnosis in the sporting environment. Research would suggest that a sideline evaluation should include a host of things: cognitive screening, balance testing, neurological examination, a vestibular and ocular motor assessment, and if all of that looks good, potentially even exertion testing. So you can imagine as the game's going on and all of this needs to be completed, it's hard. And so really at the end of the day, in any suspected case of concussion, the individual should be removed from play and assessed by a physician or licensed healthcare provider. That's the safest thing to make sure that we don't have bad outcomes following the injury. Some of the common sideline evaluations that you may hear of is the SCAT, there's a child and adult version, King-Devick, and the VOMS. And I think, the important thing to realize with these tests is not one test is perfect. There's limitations to all of them. And we know there's weaknesses associated with some of them. For example, I often see the King-Devick being used in this area, and that only looks at saccadic eye functioning. So even though somebody may pass that, there may be other objective markers that an injury is there. And so I think, my biggest point here is know what the test is capable of. As far as emergency care, the purpose of acute care going to the emergency room following concussion is to rule out more serious intracranial pathology. And really, and the biggest thing that we're ruling out is if a bleed is present. But there's really pretty distinct markers if that's the case. So some of the reasons that you might want to consider going to the emergency room is that if the headache is just continuing to worsen, it's kind of the worst headache of your child's life, loss of consciousness, seizures, vomiting. Usually this is kind of multiple episodes of vomiting, slurred speech, disorientation, significant behavioral changes, weakness, numbness, or tingling in the extremities, concern regarding a cervical injury, or any focal neurological sign. This is not all cases of concussion. I'm never going to discourage a parent from bringing their kid to the ER, but the ER is not meant to manage the concussion. They're really ruling out more serious issues. And sometimes I get parents that come back and they're frustrated that the ER hasn't managed the concussion, but that's not their job. They're trying to make sure nothing else is going on. So I think, the point I'm trying to make is know what the ER is able to do. Now, as far as concussion treatment, kind of the next step after it's been recognized on the field is in-office treatment. And generally, in-office treatment, the best time point for this is around 72 hours post-injury. So we know the first 3 days of injury is usually when you have the greatest symptom burden. So if we see you in 24 or 48 hours, it can still be pretty difficult to make all of our clinical decisions and set up, a full treatment plan, because we can inherently just with time see symptoms improve. Now, when we're doing a comprehensive clinical assessment, our goals with that is to establish the diagnosis and prognosis, provide education about the injury, identify the clinical profile or profiles involved, so we can now identify types of concussion that are present and match treatments to those types. And as I said, establish a treatment and rehabilitation plan specific for that patient. Components of our clinical assessment is going to be neurocognitive testing. So again, this is cognitive testing that if we have a baseline, we'll compare to, or else we'll use academic history or occupational history to make comparisons as far as where the data should be. Vestibular and ocular motor screening. So we're looking at your vestibular system, which is your ability to coordinate your head and eye movement, and often causes dizziness after injury. And is involved in about 40% of our cases. Ocular motor functioning is referring to the ability of the muscles of the eyes to coordinate your vision. And we see this affected in about 10 to 20% of our concussion patients. It can cause headaches, difficulty with reading, double vision in some cases. We conduct a pretty lengthy clinical interview where we're determining how that patient has done in terms of getting back to school or getting back to physical activity, what symptoms have been occurring, personal medical history, family medical history, academic history. So it's pretty detailed. And then in some cases, we're actually working kids out so that we can understand how they respond to physical exertion. Now, when we think about concussion signs and symptoms, often the common signs is a loss of consciousness, motor incoordination, difficulty getting up, disorientation. And when we think about our symptoms, we group these into 4 different categories: physical, emotional, cognitive, and sleep. Headache is the most common symptom following concussion. There's not a day in clinic that I don't see a patient that's complaining of headache, and that's followed probably by a close second of dizziness. But some other physical symptoms are light noise sensitivity, visual problems, either blurry or double vision, nausea, balance problems. Emotionally, we see patients complaining of anxiety or depression, feeling more irritable, sad, and often patients are having some trouble with rumination or trouble turning off their thoughts. Cognitive symptoms could be kind of feeling foggy, slowed down, difficulty remembering, and then patients also can have difficulty with sleep, either initiating or maintaining sleep, or also sometimes they will have feel like they're not rested after waking. Now, I mentioned that neurocognitive testing is part of our comprehensive battery. And the reason for this is that we know in some cases, patients can report to be totally asymptomatic from a physical standpoint. They can feel like their physical symptoms are gone, their emotional symptoms are gone, they're, feeling well cognitively, but we can still find deficits via neurocognitive assessment. So when we assess their cognitive functioning, we may find that it's not exactly where it should be based on their academic history or their baseline. And so without adding that component, we cannot be as certain about our clinical decision making. And so there's a big value added with neurocognitive testing versus relying on symptom reporting alone. And without that, we can be under-diagnosing concussion, and we can be putting people back to play too soon. So it's a very important part of the concussion evaluation. Now, what I typically see in clinic and what I often explain to patients is that the physical symptoms typically resolve first, followed by the emotional symptoms, and usually the cognitive symptoms are the last to fully resolve. So it is not unusual for a patient to come in and maybe they've been asymptomatic from a physical standpoint for about 2 days, but we still see some cognitive difficulties. And these resolve with time. 1 to 4 weeks is pretty normal for recovery from concussion. But again, my main point here is cognitive assessment is very important following the injury. As I just alluded to, recovery time is longer than we thought. So I get a lot of patients that come in to us and feel like, their symptoms may be dragging on longer than they expected. I think it's kind of a myth that's out there that your symptoms should be gone in about 7 to 10 days. And what we know is, by looking at it more comprehensively and using multiple tools, really, most of the recovery is within 1 to 4 weeks for our patients. And I would say most patients, it's about 3 to 4 weeks. So long story short, don't be too concerned if symptoms are still going on week 2 or week 3. That can be normal. But if they are still going on at and symptoms are not improving in severity and frequency, that might be a good time to consider getting care at a specialty clinic like ours. With symptoms, we can see symptoms vary in intensity and presentation based on the individual and severity of the concussion. Some patients may not look or even act injured immediately after the injury. We can see symptoms sometimes come on up to 3 days post-injury. It's kind of rare for symptoms to come on any longer after that point. But we can see sometimes a day go by without symptoms. We also know that getting back to school, work, or physical activity, it can worsen symptoms temporarily. But research really indicates at this point, the sooner we can be active and get back to routine, the better we do. So it is very rare for me to be keeping kids out of school or keeping our adult patients out of work. We want to get everyone back on a routine and a schedule as soon as possible, utilizing breaks to help manage the symptoms. We also know that symptoms can wax and wane throughout the day. And again, that's the important thing, to add in breaks to help manage the symptoms throughout the day. Now, another common myth is that you must be placed in a dark room to recover from concussion. And what we know is strict rest has been shown to cause individuals with concussion to experience greater symptoms and prolonged recoveries. So there has been a shift, kind of a pendulum shift, with rest not being recommended after the first 24 hours. After the first 24 hours, it's very much recommended at this point to start getting back on a schedule and routine as much as possible, knowing that you do have to feel symptoms to get better. Now, there's some issues, as far as rest, and I think if you think about it, if there's a doctor telling you there's nothing really we can do for concussion, you need to rest, no physical or cognitive activity until your symptoms resolve, it can send you into a little bit of a depression. It's like, what's the next step forward? You're sitting in a dark room. You don't really know if there's anything that can be done. All you can do is rest. And we're all very busy people. And so taking all of our outlets away, it can create problems. So some of the main problems with how rest has been associated with concussion for a number of years is that it's not well defined. Patients often take it to the extreme. If some is good, more must be better. We all want to do as much as we can to improve ourselves. But in this case, it's really not that. A little bit of rest is good, but we don't want to take it to that extreme of doing absolutely nothing, which I still see day in and day out with some of the patients that present to clinic. There's also no research that demonstrates using a cell phone or watching TV is detrimental. Yet patients get this recommendation all the time. You have to, again, expose to some of these stimuli that create symptoms in order for the systems to get better and improve. So really at this point, and this quote is from the most recent consensus statement, the best available evidence shows that recommending strict rest until the complete resolution of concussion-related symptoms is not beneficial following sport-related concussion. So if you are getting this recommendation from a provider, I would recommend you get a second opinion because you really need to be active following the injury. Another myth is that all concussion treatments and recoveries are alike. Historically, it was kind of a one-size-fits-all approach for concussion, but we've advanced that, and we're now able to individualize treatment for concussions. What we know is no two concussions are identical. Everyone kind of brings a different, background in terms of their personal history to the table that we have to take into account as we assess and make that treatment plan for the individual. As I mentioned earlier, we do have different types of concussions that we see, and sometimes the patient has one type, sometimes the patient has two types, but the different clinical profiles that have been identified is anxiety and mood. So patients can present with symptoms that are resulting from underlying anxiety or mood that has been exacerbated or caused by the injury. And so we have to work through that and manage that. Post-traumatic migraine, which is generally a pretty significant headache with nausea and or light or noise sensitivity. Cognitive fatigue, which is kind of an overwhelming sense of fatigue, especially by the end of the day, that really prevents engagement in cognitive and physical activity. Vestibular-related difficulties, as I mentioned earlier, causing dizziness, and ocular, which is difficulty kind of coordinating your vision. There's also two modifiers for concussion. And so the way we think about modifiers is they can map onto any of the profiles and make it worse. So if there's sleep difficulties, for example, if you had the sleep modifier and you had the migraine profile, poor sleep could cause worsened headaches. Similarly, if you have neck involvement following the injury, that could also do the same thing. So for example, if you have neck involvement, that could also make your headache worse too. And so we know that any of the modifiers can interfere with any of the profiles. And so we have to take all of this into consideration when we're trying to develop the treatment and rehabilitative needs. Each profile has different risk factors. So for example, if you do have a pre-existing history of anxiety, you may be more likely to have the anxiety and mood profile. Similarly, if you have a history of migraine, you may be more at risk to have the post-traumatic migraine profile. But this has really helped us advance care for concussion, which is the exciting part. Now, some of the emerging treatments for concussion, and I hope this is one of the takeaways tonight, but behavioral regulation is kind of the foundation for treatment of concussion. If you want to do one thing for your child after they sustain a concussion is get them on a good schedule. So we're always talking to patients about sleeping, having a good sleep schedule, going into bed at the same time, waking up at the same time. Not adding in a ton of extra naps or sleeping throughout the day after that first 24 hours. We want them sleeping a normal amount of time, not oversleeping. As we know, oversleeping can sometimes make you feel more fatigued. It can lead to more headaches. There's other issues that are associated with that. Exercise is actually a really important part of recovery, and we use physical activity, honestly, as medicine following the injury. There's no patient that can't walk after the injury. We usually are trying to get patients to start moving even more than walking pretty quickly to help improve some of the systems that are affected following the injury. We know exercise can help with headaches, it can help with mood, it can help decrease vestibular sensitivities that might be there following the injury. So we're very much gearing patients in terms of where they should be falling or what they should be engaging in following the injury. We also want to make sure that our patients are eating pretty consistently throughout the day, breakfast, lunch, and dinner. Obviously, in our high school population, breakfast is often skipped. So even a protein bar out the door is better than nothing. But that consistency of meals throughout the day really helps fuel the brain to get better. If you recall, I had mentioned how it's an energy crisis in the brain, and you kind of have to think of food as fuel. Similarly, hydration is another source of fuel. And so we want to make sure that we're hydrating well while recovering. Stress management is also important. Stress is a big part of this injury. There's a lot of misconceptions about concussion that make anxiety following the injury or nervousness very, very significant. And I hopefully some of the information that we've shared tonight helps you relay that, that this is treatable, we can work through it. But, I would also, one of the things that I see a lot is parents asking about symptoms a lot, or coaches asking, or there being a lot of pressure to get back to play. And sometimes less focus on the injury can actually be really beneficial during the recovery. Again, I'm a mom of three. I know how it's hard not to ask your child how they're feeling. But sometimes, if you're getting questioned about, do you have a headache? Do you have a headache now? Do you have a headache now? You're going to develop symptoms just because of thinking about it over and over again. So be aware of that, be cognizant of that. We provide a lot of reassurance in clinic to help reduce the stress, but it is a big component here. Now, moving on to active therapies, and some patients don't require active therapies. In some cases, behavioral management is enough. But in some cases, vestibular therapy is needed. Again, this is going to be if there's a dizziness presentation that we think is being caused by the vestibular system not working as effectively as it usually does. Usually after concussion, it's kind of a slow, wavy boat type dizziness that patients experience. And they'll meet with our physical therapist and get an individualized plan based on where they are functionally to help improve their tolerance of certain head movements to decrease that dizziness over time. Vision therapy is needed in select cases where we're worried that there may be something, even it could be a pre-existing component that's influencing. But a lot of our ocular motor difficulties that we see post-injury can actually be treated in-house with our vestibular therapy team. We have exertion therapy where we help patients get back to physical activity if they're struggling. For example, if they're having significant headache, getting back to physical activity, we can actually work with them to customize a plan to help them build up their physical activity levels while experiencing symptoms, but to be able to tolerate it appropriately. Psychotherapy is needed in some cases if the anxiety and mood doesn't improve with increased activity. And then in some cases, when there's neck involvement, we might need cervical physical therapy. In select cases, we might have to use medication management temporarily to help reduce symptoms so the patient's better able to engage in the recovery process. Any medications that we use are not meant to be long-term, but short-term to really help the patient get from, point A to point B. But I would say actually this is pretty rare that we have to utilize medications. The most important thing is to make sure wherever you go for care following concussion that the therapy is matched to the profile or presenting concern. Over-treatment for concussion is a big issue, something I see every day. And really, I think, less is more with concussion. I've already highlighted behavioral management, but I can't stress it enough, so it really deserved its own slide. If you're going to do anything for your child following an injury, it's getting them on a good routine and schedule. After that initial 24 hours, they should be following a regulated schedule, eating regular meals, staying well hydrated, getting good sleep, not oversleeping, getting some physical activity each day. Again, anyone can walk after concussion and be okay, and keeping stress as low as they can. As I've also discussed tonight, getting back on a schedule and routine as early as possible is important. Gone are the days that we used to keep kids out of school for weeks or months even. We really try to get them back into school as soon as possible. But to do that, we have to provide some accommodations to help with that re-engagement in a busy environment. So some of the things that we consider, sometimes we'll do a modified day for a day or two where they might do a part day. Sometimes we'll give extra time for testing, reduced length for examinations. So if they can show mastery in 10 questions versus 20 questions, sometimes that's a good approach. I can't emphasize enough breaks throughout the day. This is really where rest has gone to with concussion, is taking short breaks when symptoms reach a 5 out of 10. If our symptoms are more kind of in a 0 to 4 level out of 10, we tell them that they have to feel that to get better. I often give the analogy of a knee injury where you have to feel some pain to get better. It's the same thing going back to school. If you feel a little bit of headache, you got to keep working through it. But if you get to kind of a more moderate level headache, then you might need to take a break at that point, step out in the hallway for a couple of minutes or go to the nurse's office for a couple of minutes. Extra time for testing. If there's difficulty tolerating the hallways, sometimes we'll have them leave class a few minutes early to avoid that, at least for the initial day or two. But then again, we want them to expose to that so they don't get used to avoiding that. Really another problem that we see is if kids stay out of school too long, then they're like our little friend over here who's pulling that makeup work behind them, and that causes a lot of anxiety and stress. So we want to try to reduce that during the recovery process to avoid anxiety becoming a component that then we have to treat and manage. Now, the final step in the concussion treatment process is return to play. And so you'll see an example here of return to play for soccer. So when we're talking about return to play or engagement in physical activity following concussion, we always start with non-contact activity. So until somebody is asymptomatic from concussion, we focus on our non-contact activities. And so we break this down kind of, you can see symptom limited activity, individual sport specific exercise, and non-contact training drills. So they will start for our soccer, for example, with walking or stationary bike riding. Once they can do those exercises and stay under a 5 out of 10 for their symptoms, they're able to go on to more individual sport specific exercise. It's amazing how getting, an athlete back with their team, interacting with their friends can improve their mood and their symptoms. So they could get back and start doing some passing or shooting drills or dribbling drills. Again, all non-contact, reducing the risk for any further injury, but helping them maintain their physical activity levels. So then when they're ready for clearance, we can get them back quicker, which is always important and good for morale during recovery. The final non-contact stage would be non-contact training drills, some clearing drills, group passing, things like that. When we see an athlete in clinic, every time they're getting letters to go back to their athletic trainer or their coaches indicating what level of activity that they're at. Again, they will not be released for contact until they're entirely asymptomatic and all the objective data looks normal, meaning the cognitive assessment, vestibular and ocular motor screening as well. Often, as far as getting back into contact, we want them to have 1 or 2 full practices before gameplay. It's kind of that final safety check to make sure everything is going well prior to getting back into gameplay. So that is all I had for tonight. I hope that was helpful in understanding how we've advanced with concussion over the past few years. Some of the services that we have available at Inova Sports Medicine. We have 2 locations, one in Fairfax and one in Sterling. We also have a concussion hotline that's available for scheduling and questions as well. I really appreciate you listening tonight and happy to answer any questions.
That was absolutely fantastic. Thank you, Melissa, again for your time tonight. To say there's a lot of questions, there's certainly that. So we're going to begin to answer questions. If you still want to submit some, please either put them in the chat or the question and answer box. And we can just start rolling right off the bat. Via Marjorie, Dr. Womble, what tests are used for the neurocognitive testing, either the baseline or afterwards? What kind of do you guys run through?
Yeah, so we utilize Impact, which is a computerized battery that's well known. It's used by many of the professional teams. It's kind of I would say, one of the oldest on the market. But again, it looks at verbal memory, visual memory, processing speed, and reaction time. So there's multiple tests embedded within the cognitive battery, and then it results in composite scores based on the subtest performance.
Okay. And then I think this is a big one that just came up. We have a few of these, so I'm going to lump them together a little bit. Can you kind of talk about lingering symptoms that persist beyond just like acute episodes, or like something over a 1 to 2 year span? Where do they go next?
Yeah, so I mean, that certainly can happen in some cases, and it's something that, again, most concussions resolve in about 1 to 4 weeks, but sometimes we do have prolonged symptoms. A lot of times when we do have symptoms a year to 2 years later, it may be, unrelated to the concussion at that point in time. It might have been something that came about as part of the concussion. But we also know there can be certain things like, for example, headaches. We can all develop headaches at a certain point in our life, and the concussion might have been the contributor to start that process, but the actual concussion process may be finished. And so, for example, in that case, we may send on to neurology to help manage ongoing headaches at that point in time. Often, when there are prolonged symptoms, anxiety and mood can be a big component. This injury can change lives if it's not properly managed. And so that's something that, working through some of the anxiety and mood ramifications of the injury is really important, and being able to have a provider that's able to recognize that and help you work through that too.
Yeah, and going back to the testing, if you don't mind, Dr. Womble, are these in person, online, and kind of what's required to get one? Maybe a physician referral, and how long does it take? Can you give like a quick kind of backstory about impact tests?
Yeah, so baseline testing can be completed in person as well as at home. Usually, for at-home administration, I prefer that to be for kids who do not have a history of ADHD and learning disability. Usually it's better we can control the environment in office for anyone who may have that history. But research has shown that at home is as effective as in office. Usually post-injury, we do prefer in person. It just allows for a more comprehensive evaluation, making sure that we're dotting all our I's, crossing all our T's. Um, there are, usually neuropsychologists or the individuals administering neurocognitive tests. Certainly in the schools, the athletic trainers do administer it. But I would say neuropsychologists usually have a very good understanding of the test, and the components and other factors that may contribute to, poor outcomes or scores in certain cases as well.
Okay. And is there, back to some of the injury scenarios here, is there a different protocol for someone who might be a healthy younger athlete versus a senior who falls, walking or, going down the steps, something just commonplace?
Yeah, there's certain differences that we may use as far as different tests or symptom inventories, things like that. Obviously, there's different normative data that we would have to utilize. Um, it varies, but I think the core structure of the evaluation that we talked about generally remains the same, as well as the treatment that's available. But again, it's all about individualizing to that individual and what they come to the table with.
Okay. And then how can, and we have lots more questions. How can a parent help, as far as maybe bringing some of this information to coaches or even their student athlete? What's kind of an easy thing for a parent such as yourself?
Yeah, I mean, I think, from a parent standpoint, managing an injury at home, it's, not not creating a hysteria about the injury. Again, that's one of the things that, I dislike is the media attention on concussion. And there's a lot of poor information that's out there. And so I think having a positive attitude that things are going to get better, it may take a little bit of time, but we can get through this is very much an important part that you can play as a parent, and providing some of that positive reassurance to your child, helping them when they need help, pushing them in the right direction to get back to school and get back to physical activity. Some of those things that I talked about during the presentation, but also, getting them on a good structure and routine right away really helps with outcomes.
So another question, an injury scenario. Someone asked, is heading the ball in soccer considered safe or does it risk concussion?
I mean, certainly we do see headers resulting in concussion, but I also don't think headers need to be avoided. Headers is not my most frequent mechanism of injury, I will say. I've expressed in the past some of my concern with changing the age that you're allowed to do headers, because I think one of the most important things with headers is learning proper skill and technique. And when you're not learning that at a young age and it's pushed out now, I think it's like 12 or 13, they can start to do headers. Sometimes kids are then so excited to do headers, they're not doing them properly or not using headers when they should be used. We certainly see a lot more elbows to the head being pushed down. So I think headers has unfortunately been isolated when there's still a lot of other mechanisms, within soccer that can cause concussions too.
So let's go through with that scenario real quick. Let's say a header is resulting in some symptoms that we might think of a concussion. For a parent, you mentioned that, the first 72 hours are where the symptoms kind of develop and you figure out severity there. What's kind of the next step of of what you would suggest to a parent without knowing like exactly what's happening? Is this something where they can head to, a Go Health urgent care location, ER? And when do they call you? And the last part of that being, if they went to their primary care physician, is that something that they would refer to you?
Yeah, so it can go in a number of different directions. I mean, certainly within the first 72 hours, if you're concerned, I do think the ER urgent care is the best place to go to, again, rule out any further concerns and, get some acute guidance. What I, again, would stress with you is that the urgent care and the ERs are not meant to manage concussions. And what I see often is patients following the advice that they got in the ER urgent care for weeks or months following injury, which is not appropriate. Primary cares do refer to us. Generally, if symptoms aren't improving in the way that they expect, they'll refer over to us. You can certainly call us on your own. Again, we recommend that patients wait until that 72-hour part or mark to be seen in clinic. You can certainly call, after 24 hours and get on the schedule. But hopefully that answers all of the questions there, Kevin.
Yeah, absolutely. So there is a tough one here. It's in the Q&A. It's a little bit over my head here, but it says, my son has a heart disease, tetralogy of Fallot, and pulmonary atresia. I hope I'm saying that right. With this heart condition, for the baseline assessment in high school sports, do you feel there should be an extra layer of neurological assessment outside of the standard baseline test? So I'm guessing what they're asking is, does the standard baseline test for concussion really encompass a kind of everybody's, conditions just outside of, themselves, I guess?
Yeah, I mean, I think that's a complicated question. Obviously,
Yeah.
there are the pre-existing risk factors or a pre-existing medical condition that, could affect cognitive functioning at baseline. A baseline is very, very helpful. Without commenting kind of on your son's specific heart condition, if you were concerned that there were some issues related to cognitive functioning prior to an injury, I would definitely encourage a baseline because, again, we have a snapshot of where they were before an injury happens. If that's something that, they do better in terms of school, for example, in a more structured environment, in-person baseline testing may be better than at-home baseline testing. But I think I always prefer cases where, kids are getting accommodations in school or things like that, that we do have some representation of what they were able to accomplish before the injury, prior to an injury happening.
All right, let's see what we got. One or a few more in here. Okay. What's the effect on driving abilities after a concussion? And
So generally, what we base driving on is reaction time and then overall level of dizziness. In most cases, we're not restricting driving as long as they're able to, engage in, or sorry, as long as they're able to turn their head without getting too dizzy. And again, reaction time looks good. I often tell patients to, go test it out. You need to go to a parking lot in a safe environment with a family member and see how you do. Usually we want patients to start on kind of back roads, familiar routes versus highways. I see driving, as, or at least from what I hear from patients, is driving is more difficult if there's a significant vestibular issue because of the dizziness. So usually then the highway is a little bit harder. And that's something they may avoid for a short period until we can get that system a little bit better. But in general, driving doesn't have to be avoided.
excellent. Now, what's next in concussion kind of treatment? What care, even like, ascertaining whether you had a concussion on the field? Is there anything coming down the pipeline that, families should feel reassured about? Do you mind talking a little bit just about the research you're doing at Inova?
Yeah, so we have a pretty extensive research program through the Inova Sports Medicine Concussion Program. Again, I mentioned we have an affiliation with Dr. R.J. Ilvin, who's really a leader in the field. And some of the work that we're looking at is EMA or using devices to be able to help get our patients better, being kind of, so to speak, in their pocket to be able to coach them through specific treatment recommendations while they're, at home versus in the office. We're also looking at long-term effects in our patients, and we have actually pretty exciting results that we're in the process of writing up for publication, where we have surveyed our patients that have been cleared from our care 6 months to 4 years out. And we're seeing very, patients basically reporting that they're back to normal. They're not having any ongoing symptoms. So I'm very excited about that work as far as our research goes. I also think there is a lot of work to be done as far as the treatments that are available. We just finished a DoD-funded grant looking at the individualized treatments options for concussion based on the profile or profiles that they've been assigned or considered to have based on the clinical evaluation. So we're really excited about the articles that and results that will come from that study as well, but we certainly have some other stuff on the horizon as well.
And as part of your research, I know you kind of answered this earlier, but I think we can hit on it again. Is it true, we'll get this from Debbie, is it true that younger people sustain the effects of concussion better than older people, that their symptoms might be, easier to improve quicker and they might not be as symptomatic?
I wouldn't say that's necessarily the case. I think certainly, our athletes are sometimes more motivated to get back to their sports. So sometimes they might be, willing to push through things a little bit harder. But I see some of my adult patients get better just as quick as an athlete. So I think it's more what you bring to the table in terms of risk factors that, can make recovery last a little bit longer. If there's anxiety and mood pre-existing, if there's migraine pre-existing, car sickness history, all of that kind of, I commonly say with concussion, it kind of fights dirty. It goes after those systems that are a little weaker at baseline. And so if we have more of those risk factors, I think that's actually more of the contributing factor in terms of sometimes recovery taking a little bit longer.
Excellent, excellent. Well, I'm just finishing up putting something in our chat. All right, so what I'm going to go ahead and put in our chat includes our number for same-day appointments as well as the concussion hotline, and then obviously the web link for Dr. Womble's page on Inova and our concussion program page. So I just wanted to thank everybody. Obviously, I think Dr. Womble, I think the world of you, and I can't thank you enough for giving time to spend with the community tonight. I think we all learned a lot. I certainly learned something new every time. For everyone on the call, you will receive a follow-up email within the next few days, maybe a week at the most, with links to everything, including the recording tonight. And if you have any additional questions, you can always feel free to write them back to me on the email. And I know that some people wrote to me either through the chat or questions with something that was maybe something we couldn't answer as a larger group, and I will definitely be following up with everyone on that. Dr. Womble, anything last thing you wanted to share with the group?
Just thanks for attending tonight. I think the more we can get good information about concussion out, the better we'll do as a community. And I really appreciate you being here. Thanks for having me, Kevin.
Thank you, everybody. Have a wonderful evening. Appreciate your time, Dr. Womble.
Take care.